Thank you very much. First of all, I would like to thank for the organizer for giving me the opportunity to be here in this prestigious conference. I'm a cardiologist, and I started my career as an interventional cardiologist who made a lot of intervention for treating arrhythmias. I'm the head of the Heart and Vascular Center of the Semmelweis University, which is not too far from here. This is on the Buda side in Budapest. And this Heart and Vascular Center has a very wide international collaboration between among partners like Harvard Medical School, Mayo Clinics, National Institute of Health in US, New York Medical College, University of Florida, within Europe, Imperial College, Catholic University Leuven, University of Heidelberg, from Oulu, and even from Singapore. In the cardiology, in the last decade, there was a huge high-tech improvement. So nowadays, we are able to cure almost all kinds of illnesses, especially arrhythmias in beating hearts. If you look at the number and the indication, you can also see a significant increase in the treatment of arrhythmias, especially with catheter-based ablation, with conventional indication, but also with new indication with the use of electroanatomical mapping, like in case of atrial fibrillation and ventricular tachycardias. Other part of arrhythmia treatments are the device implantation. We have conventional indication like bradycardias, and bradycardias can be only cured by device implantation. Via the cephalic vein, we implant leads, and in the subclavian part of the body, we implant the device. But we also have devices for heart failure patients, devices which can cure ventricular fibrillation, that means sudden cardiac death, and even we do have so-called cardiac resynchronization therapy options with triple leads, which are eligible for resynchronize the movement of the heart. If you look at the number in Hungary, the Semmelweis University Heart Center had step-by-step the largest number of implantation of cardiac resynchronization therapy for the treatment of heart failure, especially with left bundle branch block. And if you look at this absolutely important method for the whole Europe, you can see that Hungary is quite okay. It's in the 1/3, and instead of we have some difficulties with the budget, but we were able to increase the number of treating heart failure patients with complex devices like cardiac resynchronization therapies. And if you look at the implantation rate of normal pacemakers, ICDs, implantable cardioverter defibrillators, cardiac resynchronization therapies, and ablations, you can see a west-east gradient. But the number in Central Europe, especially in Hungary, are quite okay. And this number is due to the high volume centers which is situated in Hungary. If you compare cardiology centers from Hungary, for example, to Germany, we can calculate maximum 20 cardiac centers, and in Germany there are more than 1,000. So that means for 10 million population, for each high volume center, we can implant more devices, and we can perform significantly higher number of radiofrequency ablation, especially as a day surgery. And the technical improvement of the devices allow us also that we can even implant special triple chamber pacemakers, that means cardiac resynchronization therapy, for that type of heart, which is a congestive heart, and these are MRI compatible also. Just behind our everyday activities, we have a very new, high-tech, modern, non-invasive methods like 3D echocardiography, MRI, or 256 slide CTs for the determination of the coronary arteries. Of course, not only the devices, but young colleagues who had experience on performing non-invasive diagnostic procedure and even invasive catheterization are extremely important. If you look at the growing number of employees at our heart center, you can see that not only the physician, but other colleagues like nurses and assistants are significantly in higher number in the last 5 years. So we were able to increase our active participants in our operation rooms, and most of the surgical and minimal invasive cardiology procedure are performed within 1 day. Of course, without investment it's not possible. This figure demonstrates how important it is to invest in new technology to provide such a minimal invasive therapy. So we need to have new MRI, electrophysiological laboratory, new CT with mobile echo, 3D echoes, and also intensive care units. So let's go back to our everyday practice, to our heart. So the heart is a very special moving organ with own nerve system. So it has a own sinus rhythm, which is a pacemaker, and a conduction system which causes the depolarization of the atria and ventricle. The short history of cardiac electrophysiology demonstrates an extremely interesting development. We started in 1903 with the Eindhoven electrocardiography, who got the Nobel Prize for this extremely important non-invasive method, which is very, very important even in everyday practice. Almquist and Rubio was the first 50 years ago who implanted the first human pacemaker. 8 years after, Sherlock from Oklahoma were able to demonstrate very small signals directly from the heart, and this was the His bundle electrogram, which demonstrated the conduction from the atrium to the ventricle. The first human implantable cardioverter defibrillator implantation was performed in 1980. In that time, it was with thoracotomy, but nowadays we perform all kinds of implantable cardioverter defibrillators via non-thoracotomy methods within a 1-day surgery, and this is extremely important method for the prevention of sudden cardiac death in a high-risk cardiac patient. From 1990, we have a method for eliminating the arrhythmogenic substrate of the ventricle, which is mostly very small particle within the moving heart. So with the help of radiofrequency ablation, we are able to map and eliminate the arrhythmogenic substrate. From 1993, as I already mentioned, we can implant special devices for heart failure patients for not only giving a stimulation, but also for increasing the function, the systolic and diastolic function of the heart. Due to the new computer technologies, we are able to demonstrate not only the anatomy of the moving heart, atria and ventricle, but also the electrical conduction. And with this help, with this new method, we can better determine, map the source of the different arrhythmias. And as I already mentioned, from 2009, we have MRI-compatible devices. So the palpitation and syncope is the most common symptoms, and in that case, we perform 12-channel ECG, Holter monitoring, loop recorder, ergometry, but we also perform some non-invasive imaging methods like echocardiography and MRI. And for the last time, if you would like to cure the patient and clearly estimate the cause and the real mechanism of the arrhythmias, we perform an invasive cardiac electrophysiological study. For the treatment bradycardia, there is only one way: implant a pacemaker. For tachyarrhythmias, for tachycardias, we can almost use ablation or different defibrillator systems. So if we perform an electrophysiological studies, we insert catheters into the right atria, in the coronary sinus, in the ventricle, and we can even perform mapping by the coronary sinus from the left side. But if you would like to go directly to the left atrium, we can puncture the septum between the left and right atrium. And if we place the different electrodes, we can find the atrial, the ventricular, and different types of signals from the ventricle and atria everywhere. After detection of the mechanism of the arrhythmias, we try to eliminate of the small area of the cardiac tissues, which are mostly responsible for the initiation of the ventricular arrhythmias, and the energy the most frequently used is radiofrequency. The radiofrequency catheter ablation has a huge success ratio. We can create well-defined lesion. There is no adverse hemodynamic effect. It has a short recovery. It is reportable and cost-effective. The potential complication rates are extremely low. The unintentional AV block is less than 1%. Cardiac perforation is also less than 1%. If you look at this experimental study, you can see the very demarcated thermocoagulated lesions within the ventricle, which is caused by the catheter-based radiofrequency ablation. If we would like to achieve deeper lesion within the ventricle for the proper elimination of the arrhythmogenic substance, we can even use special cool-tipped ablation systems. Almost all kinds of arrhythmias can be cured by catheter ablation. The very common atrioventricular nodal reentry tachycardia, the WPW syndrome, atrial flatten tachycardias, focal ventricular tachycardias, and the most common arrhythmia, which is the atrial fibrillation. The AV nodal reentry tachycardia is quite often in young ladies, which is caused by a double AV node, and in that case we try to map the so-called triangle near to the tricuspid valve and vena cava inferior, and after giving the radiofrequency ablation, the slow pathway, we can cure the patient, and the patient will be in normal sinus rhythm as demonstrated on this figure. But not only the dual AV node can cause supraventricular tachyarrhythmias, the WPW syndrome, the major difference is that in that case, the accessory pathway is situated around the annulus fibrosus, which makes a clear distinction between the atria and the ventricle. And with this extra conduction system, there will be a delta wave on the ECG, which is very typical for WPW syndrome. And the AV node itself and the accessory pathway together can create re-entry tachycardias, but not only re-entry tachycardias, also extremely dangerous, life-threatening tachyarrhythmias like ventricular fibrillation. The WPW syndrome is the most common cause for sudden death in younger age, especially in top athletes. The AV reentry tachycardia, which is caused by this reentry mechanism, can be cured around the annulus fibrosus, which is situated, as I already mentioned, between the atria and ventricle. And with the help of electrodes, we are able to destruct the accessory pathway. And if you look at this figure, it's very difficult to see it. There will be a narrowing of the QRS. The different types of supraventricular tachycardias can be also initiated from the atrium. And this is an activation map of the atrium. And in that case, we cannot see the ECG tracing as is necessary. But in that case, we were able to demonstrate the source somewhere close to the AV node. And if we ablate this arrhythmias, in that case, we can cure the patient forever, and the patient can go home, and even he can be or she can be a top athlete. This is another case of a top athlete who had a right ventricular outflow tachycardia with a wide QRS tachycardia. It seems to be life-threatening. And we performed electroanatomical mapping for demonstration of the earliest activation of the ventricle, as you can see from here. And you can see the propagation, the conduction within the ventricle. And if we are able to demonstrate the earliest activation, we need to ablate with the help of radiofrequency ablation catheter, and we can cure the patient. So there are different other types of arrhythmias, like atrial flutter, which is quite common. This is in the right atrium, and there is a re-entry mechanism. There is a circle, and in that case, we have to provide a linear lesion in the very inferior part of the right atrium, and after achieving a linear bidirectional isolation, the patient can be cured, as demonstrated on this ECG tracing. As I already mentioned, the atrial fibrillation is the most common arrhythmia. This is the irregular palpitation, can contribute to other cardiovascular life-threatening situations like stroke, and we know that with the age we had an increased prevalence. So what we have to do, we have to find out what is the underlying mechanism in case of atrial fibrillation, and we know from basic science that the major cause of initiating atrial fibrillation is the cells which are in the pulmonary vein just behind the left atrium. So in that case, we try to perform a linear lesion and isolation of the pulmonary veins. Isolation, that means electrically isolate the pulmonary vein from the left atrium. And these ablation lines are also help us to eliminate dangerous ganglions and neural networks which can also initiate arrhythmias. And how we do that? We use special ablation catheter, we use mapping catheter, we insert it in the pulmonary vein, and we perform mostly point by point an isolation from the left side. And after achieving the isolation, we can have a success up to 70–80%. Since we have electroanatomical mapping, as you can see here, this is an MRI CT integration of electroanatomical mapping, and this is the normal anatomy of a left atrium, and we can find an activation mapping or a volt mapping for better ablation for the atrial fibrillation. So with the help of such kind of electroanatomical mapping, we do every day 3 to 4 atrial fibrillation ablation, and the day after the patient can leave the hospital. Another method for achieving linear ablation or the cryoablation. So we can use such a balloon for isolation of the pulmonary vein, or we can even use special pulmonary vein ablation catheters as a multi-electrode catheter used to map, ablate, and for verifying the isolation of the pulmonary vein. Not only from the atrium, but also from the ventricle, as I already mentioned, can initiate a tachycardia. In case of ischemic patient, we do not perform it within a day, because in that case, the patient normally had a bad ejection fraction. But with a normal ejection fraction, we can perform even ventricular tachycardia ablation. So this is an MRI of a normal heart, and in that case, the ventricular tachycardia initiating somewhere from the anterior basal localization. So what we need to do, we need to ablate, we need to perform ablations points on that part, and after successful elimination of the foci, we can cure the patients. So ablation is extremely helpful for curing patients with palpitation and different kind of arrhythmias. As I already mentioned, anti-arrhythmia devices are suitable for treat slow heart rate bradycardias. So we perform most of the cases dual electrode, dual lead implantation, plus a device implantation in a pocket around the subclavia, a little bit lower. So you can see the clear development in the pacemaker technologies, and the implantation of a pacemaker, it's not a complicated procedure, and the rate of surgical complication are very low, included infection, electrode dislocation. We have new techniques for not only for bradycardia, that means slow heart beats, but also for life-threatening ventricular fibrillation. And at the beginning of the 90s, mostly performed thoracotomy for ICD, implantable cardioverter defibrillator. But due to the improvement of new computer technology, we are able to implant implantable cardioverter defibrillator like a pacemaker, as demonstrated here. And with the help of that type of pacemakers, we can clearly increase the life expectancy and decrease the all-cause mortality in patients suffered from different cardiac disease who has a higher risk for dying. How does it look like? I would like to shortly show you how we can try during the operation. How does it work? So we induce ventricular fibrillation. The device itself detects the ventricular fibrillation, charge the capacitors, and this device will give an intracardial shock which can clearly terminate the life-threatening episode. And that's what we normally can see. This is a Belgian football that the patient, the top athlete, was falling down due to life-threatening ventricular arrhythmias. This patient had an arrhythmogenic right ventricular dysplasia, and if you were quite okay, you were able to see that there was a shock given, and the patient seems to be quite okay, so he can continue probably the running and the football match. So if we are able to determine the risk for dying suddenly, we can implant such a pacemaker devices which can automatically determine, detect the episodes of life-threatening arrhythmias. In that case, the patient will be okay and will survive these arrhythmia episodes. Complex devices like triple chamber devices are also suitable not only for curing ventricular fibrillation or bradycardias. They are also very useful for cardiac recyclization in heart failure, and we implant in that case triple electrode, one in the right atrium, one in the right ventricle, and one via the coronary sinus directly to the left lateral branch. And this method is absolutely effective to reduce the dysynchrony within the left ventricle and increase the left ventricle ejection fraction, which is quite important in that type of patient population. So, dear ladies and gentlemen, let me conclude. Invasive electrophysiological studies is needed to determine the exact pathomechanism of arrhythmia before device ablation or device therapy or ablation. These are a minimal invasive procedure, absolutely suitable for a day surgery. The radiofrequency ablation itself, a catheter-based ablation, is the most effective curative therapy for most regular and even irregular tachyarrhythmias. The pacemaker therapy is the only effective therapy for symptomatic bradycardia, but the complex pacemakers like implantable cardioverter defibrillators are also suitable for reduced mortality in patients with recurrent malignant ventricular tachyarrhythmias or with a high risk for sudden cardiac death. The cardiac recyclization pacemaker and ICDs, the triple chamber or otherwise biventricular pacemakers, is a novel method to treat severe heart failure with intraventricular conduction denial. So what we can be offered by the Heart and Vascular Center for arrhythmia management, electrophysiological examinations of any kind of arrhythmias, catheter ablation of most of the arrhythmias, device implantation in a high-volume university center with a strong background of scientific activity, with high-quality instrumentation, with highly skilled, experienced, and motivated personal staff. I would like to thank you very much for your attention.